A very good morning and warm welcome to all participants from Malaysia, the SEAMEO network and our affiliated countries. Thank you for joining us today for the IMR-SEAMEO Webinar Series 2026. Before we begin with our webinar series today, let me start by asking all our participants a simple question. How long do you think a patient should wait in the emergency department before actually receiving care? Well, for many of us working in the healthcare industry, this delay is not just a matter of numbers, but in fact, these numbers can significantly impact outcomes of patient safety and their overall experience in the emergency department. Having said this brings us today to a very relevant and important webinar theme, which states as enhancing hospital efficiency and patient care through optimizing process flow and resource allocation to reduce emergency department waiting time. In today's webinar, we will explore how we in the healthcare industry can move beyond just simply optimizing resources, but instead also utilizing data-driven information and evidence to better improve our delivery of systems and functions. We are lucky to have our presenters today who come from the Institute of Medical Research, IMR, as well as Hospital Sungai Buloh. Myself, I'm Dr. Sarbhan, and today I'm pleased to be your moderator for today's session. Ladies and gentlemen, the webinar series was initiated with the main aim to share knowledge, discuss relevant topics on biomedical research, and present relevant research-related outcomes. Now, before we begin with today's presentation, allow me just to read a few simple housekeeping messages to all participants present today. Firstly, do take note that we will not be taking any questions during the presentation sessions, but participants are encouraged to share any questions that you may have through the Google link. Second, after presentations have been completed, we will proceed with the question and answer session. An attendance link will also be provided in the YouTube channel for those who would like to receive an e-certificate of attendance. And finally, please do subscribe to our National Institutes of Health Malaysia YouTube channel by clicking the notification button so that you can get new posts and new videos and new updates. Ladies and gentlemen, let's dive straight into our webinar session. So for today's webinar session, as I've mentioned earlier, we have two speakers. Allow me first to introduce our first speaker for the day. Our first speaker is Dr. Muhammad Kamarulariffin Kamarudin. He is a medical officer who is currently serving in the Biomedical Epidemiology Unit in the Special Resource Center, IMR. He holds a doctoral degree in health informatics from the University of Malaya. Dr. Kamarul has got an extensive and wide research interest in computational epidemiology and health system quality improvement. He has published many peer-reviewed international papers, books in many journals. For today, Dr. Kamarul will be sharing his work and on his research with the presentation titled Developing and Optimizing Simulation Models to Reduce Emergency Department Waiting Time. Dr. Kamarul, the screen is yours.
Right. Good morning. Thank you, Dr. Sarbhan, for the kind introduction. So my research presentation today basically looking into optimizing emergency department patient flow using discrete event simulation. So basically this morning session will be about me sharing my work on how I develop the models, and we will also look at the preliminary findings. It's still preliminary because there's some fine-tuning that works that still need to be done. And then particularly for this research, I want to emphasize on the use of open source tools or software and help whoever out there that's interested in developing a discrete event simulation. And this is basically a case study that was conducted in one of the hospitals in Malaysia, namely Hospital Sungai Buloh. And we are lucky today because we have a representation, Dr. Rossman from Hospital Sungai Buloh today, that will be sharing his experience conducting the research with me, as well as how probably he and his team can make use of the model to help with patient flow management in the ED settings. So basically, the layout of my presentation will start with me describing the background and the problem statement, and then I'll try to simplify or summarize the methodology that was used to collect the data as well as to develop the models. We'll also look at the model scope and how actually we implement this modeling in the ED zones in Hospital Sungai Buloh. After which, I'll talk a little bit about how did we validate the models and what kind of experiments that we have conducted to actually verify the model flow, some of the key results and how actually to interpret those results, and then we'll see later I'll talk about some of the limitations and strength of DES model in modeling ED waiting time. Right, basically, I think waiting time in emergency department is an issue that is not unique to Malaysian. We have heard, I think, in the literature and the news, they have reported that waiting time is actually an issue at a global scale. So many countries, even our neighboring Singapore and Thailand and Philippines, are actually experiencing the same issue where their patients need to wait quite several hours even before being seen by their doctors in the ED department. And I think this challenge persists because an effort to alleviate this actually faced with some difficulties because ED essentially is a very complex system. So in emergency department, you have unpredictable patient arrivals, you have patients with different severity levels competing for the same resources, while actually the resources are quite finite or limited in terms of numbers. And then effort to try to alleviate or to rectify this problem actually quite costly if we were to do this with trial and error method. So that's why to try and propose a different way and try to make this happen is when we think a simulation model like discrete event simulation can actually be implemented. So basically what we do is to build a virtual ED model to test the staffing distribution, and we want to test the pathway that actually the patient follow from the start to the end of the care in the ED, and this can be a risk-free environment where the policy makers or the management of the hospital can actually try out different interventions instead of implementing it at the ED itself. But then there's a virtual environment where any mistakes actually can be forgiven because this is just a virtual environment. So this model basically enables what-if analysis. So you have a question, what if we reduce the number of medical officers in a certain shift, probably to see what's going to affect, how that's going to affect the outcome in terms of the length of stay of the patient in the ED department. So instead of really doing that in real life, so you can actually implement that kind of intervention inside a virtual environment. Then the problem is, I think in the literature, a simulation study, for example, not necessarily discrete event simulation, but a simulation is quite few in Malaysia that's actually making use of an open source framework like SEAMEO package in R. So a lot of them basically quite difficult to reproduce because they are using proprietary or software with expensive license. So this study is trying to fill those gaps by proposing and documenting a more transparent step-by-step methodology of how people and researchers can actually conduct simulation models to study ED waiting time issues. Well, we adopt a 7-phase process to complete this study. The first being we have to go down to the ED in the Hospital Sungai Buloh to learn about the flow to the system. So we need to define what actually constitute a patient workflow from the start of the registration till the end and discharge either to the ward or home. So we need to define all those workflow, and of course in the study we have also to limit our scope to a certain aspect of the ED workflow. Can't be including many things at one time because in a research we are also limited by resources and time frame. So after we did all the system definition and defining our scope, we have to begin with data collection. Data collection here basically is trying to estimate the model parameters. So say for example, in the models you want to factor in the arrival of patients. You certainly need to factor in patients' arrival here because the models are actually about patients coming in the ED and then going through all the processes inside the ED. So patient arrival is one of the parameters. So we need to look for or collect data related to the rate at which patients come to the hospital or to the ED department. So after we define all the parameters needed, so we have to begin collecting our data and did some analysis. The conceptual modeling here is a process where we need to look and verify. The initial verification is it's just a verification in terms of the logical flow. So you need to make sure that the model actually accommodate the real life process. So from registrations, then patient have to go through the secondary triage, and then after the secondary triage, the workflow the patient need to go through the waiting room before being called by the doctor. So that kind of logical conceptual modeling need to be verified. And then only that we actually begin coding for the simulation model itself. So here we actually make use of an open source tools. Is a package inside R. R is a programming language that's really quite flexible and powerful when we want to do analysis, and that actually includes statistical as well as machine learning as well as a simulation model like this. So when we have developed the models, then we need to verify in terms of whether or not the model produce the output that we intend. For example, one of the verification that we did is in terms of the number of arrivals in total for a day coming to the ED department. So we validate this output with the real data that we get from the hospital, and I'll show you later what the results look like. And then when you have verified and validated the model, then we can use this model to design some what-if scenarios, or here the design as an experiment to test if we change a certain parameter. For example, if we change the number of doctors seeing the patient at a certain shift, then how that actually impact the output in terms of the patient length of stay. One of the output that we also look at is the number of pending admissions. So finally, we need to interpret the results, right? So I'll try to actually show you some of the what-if scenarios that we have conducted and the output from those experiments, and how do we use those information to help us with planning in the emergency department. So the data collection actually begin middle 2034 and actually completing a full year cycle, and the data collection actually ended in June 2025. So some of the data that we collected, there are three sources of data. One is actually from the electronic medical records, where we actually extract the arrival timestamps of the patients coming to the ED. But not all parameters actually can be extracted from the EMR. So we still need to place our research assistant to directly observe the patient flow inside the ED, and then get the time at which they start and time when they stop, for example, seeing the doctor. So we need timestamps data at different point of the patient flow. And then, like I said, part of the process is include verifying and validating the model. So that actually involve interviewing the core ED staff to ask for their verification in terms of the model workflow, whether or not the model actually captures the essentials processes inside the ED. And then all this data actually was used to calculate the model parameters. So the scope for the model, it involves 3 zones. So the green zones are the less urgent zones. And here the patient flow starts with triaging and then registration, and then waiting to see the doctor. And at this in this zone, we actually categorize our patient based on their severity and urgency of to be seen by the doctor. So there are few categories from G1 to G4, and then if the doctor requires some diagnostics, then the patient has to go through some diagnostics pathway, and then back to the doctors to review the result before being discharged or admitted. Here we also implement some priority logic. So if the patient is categorized as G1, then the patient will be seen at more urgency than the other patients that's not categorized as G1. In yellow zone is a more urgent observational level patients. So patients here, instead of being seen by the doctor, has to be assigned a bed first on arrival, and then going through stabilization, some diagnostics, and potentially being referred for a specialist review before being discharged or admitted to the ward. And then in the red zone, for critical case and for resuscitation case, here we also model possibility of the patient died during resuscitation. And then here we also try to model simultaneous investigations as well as patient being reviewed all at the same time. So part of the verification process, let me just detail that out, involve a code walkthrough. So the R code that we have written, we walk through the codes with our stakeholders so that we can confirm that these codes actually match the conceptual model. And then we also did some step-by-step debugging, and then testing out all the parallel processes that we have defined in the red zone, in the yellow zone. And then we get feedback from our ED staff after they reviewed the logic, so that it actually makes sense. And then some of the validation that we did include comparing the model output with the historical data that we get from the EMR. And then part of internal validation also, because a simulations, the output of a simulation can be random or biased to a certain extent. So we need to repeat the simulation multiple times. So from these repeated simulations, that we can get the output in an average. We can estimate the parameter by looking at the average instead of just one point estimate. And then we also include in 96-hour burn-in period, because simulations, when you first initiate a simulations, usually the parameter or the output from those parameters are what we call as their initial values that might not represent the real stabilized values. It's just a transient intermediary values that actually before you get to the real stabilized value. So we need to factor in burn-in period. Some of the preliminary findings is still preliminary, because there are some tweaking and refinement that we need to do. But based on these preliminary models, we can see that at baseline, the waiting, the length of stay of patients in the green zones are about 3.5 hours. And then we have 4.2 hours in the yellow zone and the red zones. So people might be wondering if this is a real indication of waiting time or length of stay in the yellow zone and red zone, because it seems to be quite short. But I think because in the model we did not factor in the fact that a lot of these patients are actually need to wait for example, if they are already planned to be admitted, they actually discharged out of the yellow zone, but then admitted into the observation ward instead, still in the ED. So because our model did not factor in that these people are actually still waiting inside the observation ward, that's why the number here does not really represent the real length of stay in yellow and the red zone. Some of the sensitivity analysis is just to prove that the models can be quite reliable, and in the end make sense, because if you increase the percentage of green zone arrival rate, you can see increment in the green zone length of stay. And then if you reduce the number of doctors during peak hour, you can see a tremendous increase in waiting time, length of stay in the green zone by 90%. So by looking at this sensitivity analysis, we can be quite assured that this model is quite reliable. So we did some scenario analysis, one of which is to add extra doctors during peak hours. So when we add one doctors in shift 1 and shift 3 at the same time, we can see reduction in green zone LOS by 9%. And then from 71% doctors utilization in green zone, which is I think quite restrictive, because this 71% represent a number where the doctors actually engage with patient at any one time. So 71% engagement with patient for the whole shift, that's quite a lot. So we can see that this number reduced down to a more manageable percentage, 54% of utilization when we add more doctors in shift 2 and shift 3. And then, but when we look at the KPI, which is to achieve 90 minutes waiting time before being seen by the doctors in the green zone, there's not much of improvement when we add the doctors. So this information, this output from the model basically suggests that the bottleneck is somewhere else. When I investigate further, basically because it's actually because of the triage staff. There's limited number of triage staff at that time that actually causing the bottleneck. So when we increase number of triage staff, the indicators actually improve from 60% to 70%. And then the second scenario that we look at, we try to test if there's improvement in length of stay when we increase the admission rate. So this actually try to prove that the spillover effect of when patients are not admitted at fast enough, so we have overcrowding in the ED. That's actually eventually will cause a longer length of stay in the ED department. So overcrowding or length of stay issue is not solely an ED department issue. It also is actually as an effect of management in the ward. And then this, the third scenario, we try to ask basically what's the number of what's the ideal number of doctors that should be placed in the green zone, given that we have all the parameters and we want to try to achieve an LOS load less than 4 hours. So when we did the optimization simulation, the model actually gave us that it would be ideal to put 1 doctor in shift 1 and 3 in shift 2 and 1 in shift 3, and this combination can actually serve 300 plus patients with median LOS less than 4 hours. So it's basically about reallocation instead of just adding stuff that actually we want to promote here. So the key findings really is about how do we use these simulation models to help us identify bottlenecks. And is beneficial, and I think hospital managers are really interested in knowing or quantify how much change that they can achieve by doing a certain intervention. So instead of implementing those interventions in real life, in the real setting, which might be costly and come with a higher risk, so why not use a virtual model that you have validated instead, that can provide you a safer environment to test out your intervention before you commit to doing that in the real setting. So it's about reallocation other than just simply adding stuff. So given a limited number of resources, you want to try to redistribute. So to do this, you need some information, and this simulation model can actually help in that sense. And then SEAMEO modules from our package is basically a modular, meaning you can change a certain aspect without changing the whole model itself. So this can, and since it's free, so people are have the more freedom to play around and then try to build models that actually make more tailored towards the ED setting in their particular hospital. But of course, I have to be transparent here. Models also comes with some limitations. Because in my model, we did not factor in the fact or the possibility that the acuity or the severity of a patient's conditions can change. So patient can deteriorate from first being seen at the triage while waiting for the doctor. Patient condition can deteriorate. So we did not take that into consideration because we fixed their acuity levels at first being seen at the triage. So this might not reflect the real event that can happen in the ED settings. And then we also did not factor in staff interactions, as in staff might need breaks for prayer, might need break for their lunch, for their dinner. So we assume that everything goes on continuously. So if the doctors, they need to see the patients continuously until the end of the shift. So then that might not be realistic, but then this is just an initial models that a prototype, if you like, that we need to refine further when we see the need. And then, of course, we did not also take financial feasibility as a scenario as a factor. And we did not assess the financial feasibility of doing a certain intervention, because this is just a what-if scenario or experiment that we do in a virtual environment. So the next, in the future, if whenever we would like to take this up, or for this research even, we are actually interested to expand this model to look at the entire hospital network instead of just looking at ED settings. Because as I said earlier, there's a spillover effect, some not really mismanagement, but then inefficiencies in management of bed in the ward can also cause a spillover effects that actually cause overcrowding in the ED due to the delay in patient being cleared to be admitted into the ward. And if possible, I mean, to be more useful, we could also incorporate economic analysis and patient satisfaction metrics. So in conclusion, this research is really about providing a transparent step-by-step reproducible methodology for DES. If anyone is interested to make use of this model, to look at multiple issues. In this case, we are looking at the ED waiting time in the ED. And then I think it's really about how we can reallocate or redistribute our staffing or our resources instead of just simply adding more or reducing or make things less. And this is meant to be a holistic system-wide approach that actually making use of open source, modular, and adaptable framework for continuous improvement. With that, I say thank you, and back to Dr. Sarbhan.
Thank you very much, Dr. Kamarul, for the very detailed and very technical presentation. So just to put it into a very simple layman's perspective of what Dr. Kamarul and the team had actually done is, we have an issue, we have a problem. What is the problem? Our ED waiting time is on the rise. Now we have data collected in hospitals. So what we do is we take this data, we formulate a model, which what Dr. Kamarul and team has done. Why we come up with a model is so that this model is able to provide what-if scenarios, possible scenarios when we try to play around with optimizing various resources, as we know that resource is something which is limited. And then this model will in turn provide some form of outcomes, which is in a virtual setting. And now it's up to the stakeholders or the clinicians or those who are at the field to say that, yes, this may be a right way to go, this may be not a very right way to go. And this is actually exactly what using data to drive evidence is all about. But we need to be careful that any model may not be exhaustive in nature. A model is only as good as the data that it has and whatever designing techniques and validation that is there to develop the model. Now, having said that, now I know there are a lot of questions. I would like to inform once again the participants to keep your questions, share it in the link, which we can address after this. Now with the model, we are now very interested to see how we can utilize and see the implicative value of this model on the real world setting. And for that, we are actually very, very fortunate for me to introduce our next speaker who can actually guide us or share the experience. And we have today with us Dr. Rossman Hawari. Dr. Rossman is a consultant, emergency and trauma physician with over 10 years of experience and is currently working in Hospital Sungai Buloh. Dr. Rossman has also completed his subspecialization training, okay, in further advanced trauma. He's also been involved in many research awards and trainings, and currently is also in charge of the, as a coordinator of the bed management unit in the Selangor State Health Department. So with that, it is our great privilege to actually invite Dr. Rossman to once again share with us his presentation on how we can move forward the preliminary findings from this research to actually utilizing and implicating these simulation models at the emergency department setting. With that, over to you, Dr. Rossman. The screen is yours.
Thank you, Dr. Sarbhan. I would like to take this opportunity to thank the organizer for giving me the opportunity to present for today's webinar. And today, the title of my presentation is the utilization and implication of simulation model at emergency department setting. And Dr. Kamarul have presented on the technical details on how we did the study for the DES. And as an introduction, as we all know that especially in the Klang Valley, this is a common scenario that we can see in the emergency department, especially in the tertiary hospitals, whereby the emergency department is having a overcrowding and access block challenge. And overcrowding occurs when the identified needs for the service exceeds the available resources. And the access block is the delay in transferring the emergency patient to the inpatient wards. So as mentioned by the previous speaker, that this issue indicates a lack of a whole hospital integration rather than just an ED problem. The symptoms might manifest in the ED, but the problem is a system-wide issue. And it's a complex problem with no one solution fits all. But this simulation model explore how can we use this approach to identify any bottlenecks that impact the patient flow and the provider efficiency. So as you can see in this graph, between the wait time and the BOR, you can see the wait time doubles from 80 to 90, from 80 to 90 utilization, and then doubles again, moving from 90 to 95. So when the hospital occupancy is increased more than 80, you can see there's an exponential rise in the wait time. And as we all know that currently our BOR or bed occupancy rate in the hospital is quite high for most of our hospital, and if you and you can imagine how the situation in the emergency department currently, and this ED overcrowding and access block may increase the mortality and morbidity for the patient, and also cause patient dissatisfaction, and more and also there's a hidden cost or the second victim, whereby this situation impact the health worker burnout, and it's a vicious cycle for all of us. So I think that's why the Ministry of Health is very serious to tackle this issue, and we hope that we could find solutions that is effective to solve this problem. Okay. So basically, if you want to have a framework, probably the attendance from the community, the patient who has a disease, who is critical, might go directly to the ED, and there is a patient from other public or private clinics that where the patient have seek treatment to the clinics and be referred to the hospital in the ED, and also from another hospital that we've been transferred from a district hospital to a tertiary hospital. So there are some bottlenecks that we can identify that cause a snowball effect downstream. So we have an exit block and an access block, and also it causes the accessibility to the hospital. So we could target a few interventions, and in the ED, that is our circle of influence that we can manage at this point of time. So we will try to find a solution that we can work on, and we are lucky that that Dr. Kamarul have chosen Hospital Sungai Buloh to do his study, so that we can try out the solution that he is proposing. So the analytical engine, as the Dr. Kamarul has explained before, could help us in doing a simulation that is reduce the risk in trying out an error in a complex problem like ED pending and access block. This could probably refine or we can concentrate on the solution that we can, because if we have only 1 ringgit, where do we spend that 1 ringgit, and how can we stretch that 1 ringgit on our healthcare system? So I think this has been explained by Dr. Kamarul about discrete event simulation. Is a virtual time-based model that mimics the exact pathway of patient, staff, and resources, and it captures the variability which the standard spreadsheet average cannot do. And the value of this is that we have a digital twin of the ED. So we can have a risk-free sandbox where we can test physical layout changes or staffing rosters or new triage pathway without disrupting live clinical operation. And it could identify failure points virtually. So we can see where the new, for example, new roster costs a 5-hour wait before it happens in reality. And so we can shift our decision making from I think and to the data shows, and this transform the ED to a risk-free sandbox, enabling an evidence-based shift from intuition to a data-driven certainty. So I would like to demo. This is the streamer package that we use for the study, and it's important that we use an open source, so that is for open science, that we can the study can be reproducible, and we can share this with others. So this example is that this dashboard, we have a few variables, and how we can set this iteration of how many iterations that we need, and we did 100 times. So, and then we get the result after a while, and then we can get this is a stochastic graph where after how many times the simulation is done, it will get a more stable value. And we can change the variables that we want. Like, for example, we can change the human resource in the shift or the triage and run back the simulation and see, is there any improvement from that changes. So this is what we call the virtual digital twin and digital sandbox, where we can try out a few scenarios and what if scenarios and see which one is the best solution that we can come up with. So this is the what if solution that we tried out. Scenario 1 by adding the medical officers during peak hours, and then we tried the scenario of increasing the admission rate by 10, and the scenario 3 resource optimization, and we can see that there is some reduction of the waiting time. We can see that adding an medical officer have a marginal reduction compared to increasing the ward admission rate, which is more have more impact on the ED pending and access block. So the thing is, how do we shift from the microchip to the bedside? How do we do it practically? An anecdotal, I would like to share my experience is that when I started out as a medical officer in the hospital Singapore, so I was taking care of the green zone alone. So I wanted to meet the senior medical officer, saying, why is it I'm alone in the green zone? And then the senior medical officer said to me, Rossman, did you know that before this, we had to take care of the research zone? And when we are free, we can see the patient in the green zone. So when you come, the solution is better. So now we have more medical officer in the green zone, but we still have the same issue. So there is a gap between how the simulation or what we think that the intervention can impact of the intervention and the real world impact. So probably one thing that I was thinking about was that maybe this could be explained by if we look at the healthcare system as a complex adaptive system, because it's not a cause and effect directly every time that when we say we put up increase the number of medical officer, but we don't see the effect that we wanted. So if we look at a complex adaptive system thinking for healthcare, the definition by John Holland is that a complex adaptive system is a dynamic network of agents acting in parallel and constantly reacting to what the other agents are doing, and in which turn it influences the behavior and the network as a whole. So we have from the klinik kesihatan, and we have patients from klinik kesihatan, we have referrals from other hospitals, and we have ED. We are not working in silos, and we refer to other specialties like medical, and the in-hospital specialty also is depend on the imaging and the lab services. So we are all interconnected, and we are the agent for in this system, and we have our own interests, but that influence how that behavior regulates in that system, that the pattern that we see in like pending admission and access block in the hospital. So the characteristic of a complex adaptive system is that it's a large number of elements which interact dynamically, and any element in the system is affected by and affect several other systems. And the interesting thing is that it's a non-linear interaction. So small changes can have a large impact, and it is also openness. So it may be difficult to define system boundaries, and a constant flow of energy to maintain the organization of the system. And there's the history impact whereby the past helps to shape the present behavior, and the element in the system are not aware of the interestingly, that the element in the system are not aware of the behavior of the system as a whole and respond only to what it is available known locally. And so this is one, this chart, the complicated chart, just to illustrate that a complex adaptive system is very difficult, and this is what they tried to do in Singapore, trying to map out all the interaction that can cause the access block or ED pending. So how, but I mean, over the years, we feel that all the initiatives we've done have marginal impact, or we feel that nothing has changed. but we cannot live in despair, and we need to do some action to bridge the gap between our current reality and future reality, that hopefully one day, when the health white paper for Malaysia, the initiative done, can be fruitful, and that will be maybe 10 or 50 years down the line. So maybe we cannot see that impact, but we cannot wait until perfection comes, but we need to do something. So for emergency department, our circle control is in the emergency department. So one of the things that we implement, so we got from the modeling, we know that we need to, if we increase the human resource, it does impact the waiting time, and we reallocate the timing. So how to implement this in the real world? So if we want to increase, it's easy to say, okay, we want to increase the human resource, but the reality is that there's no human resource available, and we know that there's a limited amount of medical officers that is available. So how did we overcome this? So we added the emergency physician in the green zone in the shift, and we, as in the model, say that we need to allocate into the time in the second shift. So we put our emergency physician in the PM shift. So we have 2 PM shift rostered in the weekdays, and this can cover the workload in our emergency green zone. And that's how we try to translate what we found from the study, and that is not enough in terms of we know the solution, we know the problem, we know the solution, and we try to, but there is the execution part is important also. So one of the intervention that we put in the green zone is to put the QMS system, and we are thankful to the state health department for providing us the software iQMS at GKNS for our queue management system, because before this we were using we were just calling out the patient's name one by one. And if this is a point of view from the medical officer, when they come into the green zone, when they start the shift, and they see all this slip of paper which represent the amount of patient that they have to see. So we are all human, so that sometimes we will cherry pick which patient that we want to see, and we try to some of us will try to take the easier cases and leave the complex cases to others, and cherry pick which one, and this might cause a delay in the waiting time. So by implementing a QMS system which have an algorithm how to distribute the cases among the in the ward, in the consultation room. So we optimize, because this is an in-house built system, that we can optimize the algorithm inside to see which is the algorithm that is most efficient to distribute the cases, and this reduce this forcing function, improve the waiting time in the green zone. So the devil's in the details, because the queue management is not something new. All hospitals have it, but the way that you implement it in your system must be localized. And one thing that probably the model cannot measure is that the human experience in terms of we created in the green zone also the customer feedback, whereby the patient can give can scan the QR and give feedback to the patient, to our doctors, so that we know that how we improve. And this also helps to protect our medical officer, whereby when we have a complaint, we can see review back what was the past review from the other patient. So in generally, most of it is that sometimes we get a complaint, probably it's just a one-off issue, but generally the medical officer was a good officer, is a good officer, and only that time probably he didn't smile or something that the patient complained. So we know this is a way for us to protect, and we can know how we are performing. And also we increase the area whereby because we don't have space to put the patient in the who are waiting for admission. So we created a green zone admission and discharge launch, whereby we increase the rate of the patient that we've been discharged but waiting for the family members to take them home. So this can free up the empty bed in the ED for other acute patient. And one thing, another intervention that we did was to put in the green zone observation counter, whereby we put our staff in the counter in the green zone waiting area to do a surveillance triage and a customer service, so that if the patient have a issue, they can find somebody and we can resolve the issue immediately. And probably the model cannot quantify this in terms the impact of this. So we have like a Google review that the customer give a good 5-star review in the Google review. And another circle of influence that we still can manage in the ED is that how when the ward have provided us with bed for the patient, there was a problem with communicating our various staff, like the nurse in charge for the MAs and also the PPK. So what we did was that to create a dashboard that monitor all the beds that is being allocated to the ED patients. So when the name comes up in the list, the in charge staff nurse or MA will take the action of trying to prepare the patient to be admitted to the ward. So hopefully we reduce the gap between the decision and physically sending the patient to the ward. And so this reduce the pending in the ED. And also, as the diagram that I showed earlier on, one thing it is one of is a hospital-wide problem. So a solution that we have to look at is not just in the ED, but we have to find another solution, other solution that is system-based. So one of the solution that Hospital Sungai Buloh implement is to have a central discharge launch, whereby same thing as the admission, the discharge launch in the green zone. This is a bigger launch where any patient in the ward in the hospital floor who is deemed safe to go home, but waiting for the caretakers to take them home, because what we find is that probably the decision to discharge is earlier in the day, but most of us are working and 9 to 5, and the caretakers is only available after 5 to take the patient home. So while waiting for that to happen, we can transit the patient to the discharge launch and complete the discharge documentation and take the medication and all the administrative part of discharges, and we can free up that acute bed in the hospital floor, that we can take up new patient from the ED and reduce the pending. So the future horizon for this study is that, as I think Dr. Kamaru have mentioned also, that we want to see that can we implement the DES in a hospital-wide system, because at the moment we focus on the ED only, and we can see that by increasing the MO, we have a marginal increase of pending, and the more important solution might be found outside the ED. So to fully understand the system, maybe we can extend, if anyone who wants to take up this study and extend it from end to end, you know, from admission from the hospital door to the discharge. And another thing that we were hoping, if we could integrate transitioning from the simulation what if to a prescriptive AI, where what we should do right now, and if we are digitalizing our healthcare system, probably this could be improved, the data collection can be improved more easily, and we can have the data collection can be automated, and we can have a better model, because we can collect better data, and we can integrate it with AI, and we can have a real-time operational dashboard that dynamically alters the suggestion of the patient flow throughout the system. And we can combine the operational, clinical, like electronic health record, and also the administrative part, and the communication between various stakeholders in the hospital. And this might improve the patient flow, but this is a very high effort, and but will be, I think will have a big impact on the health, on the patient flow. And this is one of the examples that we are trying to build for BMU JKNS, whereby each hospital have a dashboard to see the health of the system, and we try to integrate the data that is collected about the bed and the admission rate, and the pending and in the ED, and the pending discharges, and how many usage of discharge launch. And we try to see whether this AI could also help us in giving us a nudge to improve the flow. So that's the end of my presentation. And the conclusion is that the emergency department or the healthcare system is facing an overcrowding and access block problem, and a traditional trial and error operation changes might be costly and clinically risky, and the DES offer a digital twin of the ED, which is a risk-free, data-driven environment to test operational intervention before the real-world implementation. And the execution of identified potential areas of improvements must remain grounded and practical to ensure that success in the real-world translation due to the complex additive system of the healthcare. And that's all for me from now. Thank you very much. I give back the screen to Dr. Sarbhan.
Thank you very much, Dr. Rossman. As you can see how Dr. Rossman has very patiently and clearly described the potential utility value of the DES model in coming up with all the various types of intervention at the emergency department setting, which Dr. Rossman has pointed out, with the ultimate aim to address the problem of waiting time. And what's important here to take note from Dr. Rossman's presentation is the term complex adaptive system. So the DES model has the current potential to actually go just even beyond the emergency department to further levels, further wards, further departments within the hospital, because this is a complex system. It's a chain system where one would affect the other. So having said that, we can now move into the next session of our webinar, and this is the Q&A session. For this, I would encourage participants or our viewers to keep sending in questions through the through the YouTube link, and we will try our best to address to all those questions. So now let me first access the first question. Right, okay. Okay, yeah, so we have a question from one of our participants, and the question goes as, are there any suggestions on how the relocation should be done given different specialities of the staff? So I believe this could be referring to I believe human resource relocation, or maybe any other. And for that, I would like to have Dr. Kamarul to provide some feedback on this question. Dr. Kamarul?
I think this particular question is also relevant for Dr. Rossman, maybe to give some opinion about later. But then from modeling perspective, I would say that well, it's always a try and error, right? Even in the real world implementation, you have to try and error, but then it comes with a certain cost and risk. But then in this virtual environment, in the ED simulation, you can actually try and error again, because there's a lot of parameters that you can actually tweak and play around with. So essentially, you don't know which of those potential resources actually is the biggest, is the cause of the bottlenecks, is the bottleneck. So if you don't know, if you don't have any idea, if you don't have initial findings to guide you, then I guess the answer would be to try and error again. But then another way of looking at this, you can always use optimization methodology, whereby given a certain restriction or a certain limitation or some objective function yang you want to incorporate into the simulation itself, or the model itself, can tell you how to relocate, how to redistribute your staff. But then this is just purely theoretical and from the perspective of the model itself, where the model did not take into consideration other factors that might not be measured initially. So for now, that's, I think, the answer. You need to still try and error, but then this in a more controlled, risk-free environment. Back to Dr. Sarbhan.
Okay, thank you, Dr. Kamarul. I think it's also, maybe we could get Dr. Rossman's feedback as a clinician on the same questions. Any suggestions on how the relocation should be done, given the different specialities that are available among staffs in the emergency department setting? Dr. Rossman, any thoughts on this?
Thank you. I guess in terms of, given the different specialty of the staff, is it in terms of the category of doctors, MA, staff nurse, or the specialty in our medical, surgical, base or pediatric? I would go for the first one. Let's say how we want to relocate the different category of staff. As the study has shown, Dr. Kamarul mentioned that, you know, one of the things that we noticed is that one of the reasons that the waiting time was long, because patient was queuing in the triage. So in those things, so we can identify, probably we have to increase the availability of the medical officer, the assistant medical officer in the triage area. And in Hostel Sungai Buloh, what we try to do is that we increase the number of assistant medical officer in terms of their penyalia, and also we put in medical doctor in the triage to improve the triage process in our department.
Okay, thank you so much. Thank you so much, Dr. Rossman, for that feedback, and also Dr. Kamarul. So we have time for one last question, and let me just read it out. This question, I think, would be best for Dr. Rossman. So if you could fix just one gap in the primary care system to reduce green zone congestion in the emergency department, what would it be and why? I think this is a very, very important question. It's a burning question. So thank you so much for this question. So Dr. Rossman, what would you think would be one gap in your opinion?
So, if I have to pick only one, I resonate with our KKM white paper, whereby we are concentrating on the primary care. We have to improve the primary care healthcare delivery, whereby if the gap in our society, there's the health determinants of our health is that we have to, it's the old saying, prevention is better than cure. So the one gap that I would like to see if we can, all of us, we can improve our health behavior and take care of if we have the disease, we can control or manage the complication or try to prevent the complication from happening. So, for example, if we have diabetic, so if the primary care can we give more resource and better system, and we can improve on the diabetic control, and this will prevent patient from having like diabetic ketoacidosis and have to be admitted to the hospital, and this can reduce the load that need is in the hospital, and also beside the primary care is the public health policy. Probably the controversial to give a sugar tax, something like that. I mean, we try to change the system that can improve. Like I think one of the initiatives that public health policy that I hope will have a big impact is like the generation end game for the smoking cessation. So I hope we can see that impact in the future.
Thank you very much, Dr. Rossman. So as you can see that there is no one fit solution. So that one gap that was asked, so Dr. Rossman has given many, many strategies for that one gap. And that actually resonates very well with there is no single one fit solution for all. Okay, ladies and gentlemen, we have actually come to the end of our webinar session. Additional questions we would address using our email. And I hope that this session has actually sparked interest and also some form of knowledge with regards to participants or our viewers on the current topic. And I would like to thank, first and foremost, all of our participants for their support to making this webinar session a big success. And also a big thank you to both Dr. Kamarul and also Dr. Rossman for all their efforts, time invested in this. And once again, please do not forget to subscribe to our National Institute of Health YouTube channel, as this would be very helpful for us to share whatever research-related knowledge. And before I conclude on the current webinar session, I would also like to drop in a gentle reminder that we will be having our next upcoming IMR-SEAMEO Webinar series, which would be held on the 22nd of May 2026, which is next month. So please mark your calendars, be available, and the theme for the upcoming webinar is titled Advancing Allergy Diagnosis and Research in Malaysia from Bench to Bedsides. So with that, we hope you can join us at the next session. Until then, many thanks from all of us at IMR. Take care and stay safe. you.